Good morning. This is Dana Parsons with LeadingAge Virginia, and I just want to welcome you all to our Coronavirus Weekly Member Update. Thank you so much for being on and taking the time to be on this call today. We would like to begin with our update from the Virginia Hospital and Healthcare Association.
Hey, good morning, Dana. This is Matthew Mary. Can you hear me?
Yes.
Excellent. Thank you all for including us this morning. As everyone is very well aware, as COVID-19 has progressed through the Commonwealth, our vulnerable populations are unfortunately really starting to see the impacts of this virus. An update as of this morning, as reported through our system, we had 316 confirmed cases, 132 cases pending in long-term care facilities throughout the Commonwealth. Along with that, on the hospital standpoint, through our system as well, we had right around 1,300 hospitalizations reported, along with bed capacity. Still plenty of bed capacity throughout, but the hospitalizations confirmed and pending has went up over the last 24 hours by 60, along with current COVID ICU hospitalizations going down, along with hospitalizations on ventilators decreasing as of yesterday, and number of discharges in hospitals has increased, which is certainly good. On the testing side, the turnaround time on testing over the last several weeks has greatly improved, and huge thank you especially to the Commonwealth and the lab for increasing the capability to ensure that these test results within the hospitals become a priority along with the long-term care facilities. I do highly encourage all long-term care facilities, especially along with assisted living and so forth, those who have VHOS accounts, to continue to update daily. We've brought in our VHHA data analytics team to assist with this data processing, but it also gives our healthcare coalitions a perspective throughout the Commonwealth for us to address the needs of these facilities. I would like to remind that the long-term care facilities, especially those impacted with staff and residents with COVID-19, to continue to reach out to your healthcare coalitions within your region regarding PPE needs. We did receive the last of what we believe would be the strategic national stockpile, and don't see any state or federal PPE coming into the Commonwealth in the very near future. And so we will be getting that PPE out to facilities that are in dire need, but a big ask is to those facilities who are currently not impacted to please be mindful on your PPE requests, as we do have several facilities that are being hugely impacted with COVID-19 cases at the time. But we would like to thank the participation within the VHOS system and with our healthcare coalitions through this response. Has been a huge success, and we can't thank you enough for, I know updating daily is taking up time within your busy schedules, but this data assists not only us at the Hospital Association, but also state leadership to ensure that our long-term care and vulnerable populations are being taken care of and remain a huge importance throughout the Commonwealth during this response. Thank you, Dana.
Thank you, Matthew, for that update. We really appreciate it. At this time, if you have any questions, can you please submit those into the chat box for the Hospital Association? Will you be able to stay on the line in case some additional questions come in, Matthew?
You bet.
Great, thank you so much. I'd like to move over to Eric Bodine, Director of the Division of Certificate of Public Need, to discuss some Executive Order 52 reminders. Okay, well, we will come back to Eric. If I could go over to Sarah Lineberger with the Virginia Department of Health to provide us with an update. Over to you, Sarah.
Okay, can you hear me?
Yes, we can hear you. Thank you.
Good morning. So as of today, there have been 6,500 confirmed cases of COVID-19 in Virginia, including 195 deaths. And I wanted to make sure you all are aware that daily updates, not only for confirmed cases, but now also for outbreak data, are being posted daily on the VDH website. I can put that link in the chat. But as of today, there have been 60 outbreaks in long-term care facilities. That includes nursing homes and assisted living facilities, out of a total of 108 outbreaks across Virginia. So that's about 56% of outbreaks, COVID outbreaks, are happening in long-term care facilities. So a couple other things to make you aware of. Yes, we're getting a lot of questions about point prevalence surveys and the utility of using those in outbreaks in long-term care facilities. We posted guidance yesterday on the VDH website on general sort of description of point prevalence surveys and when you would use them. And so I would be happy to answer questions about that, and I can put that link in the chat as well. In general, let me see. In general, a point prevalence survey can be used to identify the number of people with COVID-19 at a specific point in time. A point prevalence survey may be used at the start of an outbreak investigation to determine how widespread COVID-19 cases are in the facility and to help guide infection control recommendations. However, if an outbreak is already widespread in a facility, a point prevalence survey would likely not change the control recommendations. And in general, as you know, we're being very stringent on control recommendations already. Everything we've talked about designating an area of your facility, cohorting patients, cohorting staff, et cetera. So we're really sort of taking all those infection control recommendations into account in all facilities anyways. If a patient tests negative on the day that the point prevalence survey is conducted, they may later test positive. And so in a rapidly evolving situation, repeat testing may be needed because, again, a point prevalence survey is just sort of a snapshot in time and telling you what's happening in that facility that day. And we continue to recommend that testing of asymptomatic staff is not currently recommended for various reasons. So public health is and has been prioritizing testing of symptomatic healthcare workers, but we're not recommending testing of asymptomatic staff. Sorry, I'm going between documents. Okay, so just other things to mention, CDC updated their infection control guidance on April 13th, I believe, and that included more guidance on cloth masks. So we've been already saying this in long-term care facilities, but now CDC is saying to implement source control for everyone entering a healthcare facility, regardless of their symptoms. So not just long-term care facilities, but now also in hospitals and other healthcare facilities, everyone walking in the door should be wearing a mask of some sort. I know you all asked questions about cloth masks last week. Face masks, like a surgical mask or a procedural mask, should be worn by healthcare providers in the facility if at all possible. Those are considered PPE, and that will help prevent healthcare workers from sharing their own germs, but also protect them against germs from other people. healthcare providers shouldn't be wearing cloth masks in facilities unless you're just absolutely out of face masks. But cloth coverings may be appropriate for visitors and residents in your facilities. If somebody's coming into your facility without a mask, having a supply of cloth masks to hand to someone to put on would be appropriate. But cloth face coverings are not PPE, and so again should not be worn by healthcare providers if at all possible when in the facility. Certainly a cloth mask would be appropriate for a healthcare provider when they're going home or outside of the facility, but shouldn't be worn as if it's PPE in the facility. We've gotten some questions about testing, and I know you all had questions last week about testing. Testing capacity continues to expand both at DCLS and hospital labs, as Matthew was mentioning. We're looking to update public health criteria for priority testing again this week. Again, long-term care facilities should be working through their local health departments for testing of residents or staff. And once a case is reported in a facility, testing kits can be provided to the facility for testing on site at the long-term care facility. And the local health department can help your facility make decisions about who in the facility should be tested. So that's all I have right now. Thank you.
Sarah, we got a question come in the chat box for you. Why are EMS workers being told not to be screened when entering our facilities? Long-term care facilities are not comfortable with this, especially if they're not utilizing proper PPE.
Sure, that's a good question. I can certainly check with the Office of the EMS, but my understanding on that recommendation is that EMS workers are being screened elsewhere. So for example, at the start of their shift. And so we're saying that they don't need to be screened at every point along their shift that day if they've been screened like that morning, for example, at the start of their shift.
Thanks. And this question is I think for Matt. What % of facilities are updating their COVID status in the VHAS system?
Can you hear me?
Yep, we can hear you.
Excellent. With hospitals, we have all but 7 hospitals as of this morning reported within the last 24 hours. Long-term care, which as expected, there are significant more facilities throughout the Commonwealth. And a good example, just 2 days ago, we had over 100 facilities that had not updated. As of this morning, we had that cut in half, right around the low 50s. So still not perfect, but we've made a lot of headway over the last several weeks with long-term care's participation in the status board updates.
Thank you. Okay, Sarah, some other questions are coming in for you. Have discussions begun about app tracking of active exposed immune individuals and their travel pathways, i.e. the Apple-Google joint venture?
I think there are a lot of discussions right now about tracking in terms of doing contact tracing and how to do that in light of just the great volume of cases we have. So I think more will be coming on that. I know a lot is being explored with regards to that. We've been getting a lot of questions about serology testing too when you mention immune individuals. And so more information is being put together on that and how those results would be interpreted.
And then another from a member who said, I think most of us right now do not have enough procedure paper masks to hand out to staff, as these can only be reused a few times and can't be washed. We've been asking our staff to cover the procedure mask with a cloth mask and keep getting cloth masks that can be changed a few times a day to protect the paper mask. So for clinical staff, cloth mask plus surgical mask, what is your take on that?
Yeah, that's a good question. We're hearing that a lot. We're hearing that with N95 masks too, that people are putting that down in like a cloth mask. I think we're all doing the best we can right now, and so I think that makes sense if that's what you can do based on your supply.
Thank you. Okay, another question came in. What about non-direct care workers wearing cloth masks, such as housekeepers, dining services, maintenance activities?
Yeah, we talked about that last week. I think that makes a lot of sense for folks who normally wouldn't be wearing PPE or aren't doing any direct patient care, that they would be thinking about social distancing the same way they would in the community that they would when they're in your facility. So I think absolutely it makes sense for dining services and those types of folks who aren't coming into contact with residents or their belongings to wear cloth masks. I would caution that housekeepers are typically are exposed and typically would be wearing PPE, for example, in an isolation room. And so for housekeepers, I would think more along the lines of PPE and.
Okay, great. Thank you. Dana, that's the last question that's come in.
Okay, great. Well, thank you so much, Sarah. And I apologize, Eric Bodine from the Division of Certificate of Public Need was on earlier, but had some muting issues. But I'd like to hand it over to Eric now to talk with us about some reminders related to Executive Order 52. And you will need to unmute yourself, Eric. Okay, well, let's move on and talk about issues related to member perspective on developing a COVID-only unit and also employment compensation incentives. I'd like to hand it over to David Abraham and Rebecca Morales from Beth Shalom Village.
Hi, how are you all doing?
Great, thank you so much for being on today.
I was worried we were going to have trouble unmuting as well. I told David, I don't know how to unmute this thing.
Yeah, I texted you, so ignore the text, as you apparently did, Dana. Good morning, everyone. I'll certainly turn it over to Rebecca here in a few moments to discuss what our workaround was on developing a COVID-only unit. But one of the things we were passionate about with regards to employment compensation increases is trying to get as much to the frontline staff as we could. On or around March 1, we made the decision to front load some additional wages for frontline staff who were essentially making $15 or less. So if staff were making $15 or less and they had anywhere between 0 and 5 years of service, all in, they got an additional $1. If staff had between 5 years and 10 years of service, we gave them an extra $1.50 immediately. Our fiscal year does begin 7/1. We are also equally as passionate about getting some additional dollars to frontline staff, as well as additional staff who make over the $15 threshold. Before I turn it over to Rebecca, for the folks who are working on our COVID-only unit, we did increase their pay as well. Anybody that works on that unit, whether it's a nurse, whether it's a CNA, whether it's a housekeeper, they're all getting an additional $3 an hour to work. Excuse me, an additional $4 an hour to work. So again, we just want to make sure that people are very passionate about what we're doing. We've had a lot of staff step up, volunteer to work that unit. And I think just generally speaking in these times, we wanted to do as much as we could for staff under that, who were making under that $15 an hour. And with that, that's really all that I have. I'll turn it over to Rebecca to discuss more of the dynamics around the unit itself. And then certainly if there's any questions, we can take questions.
So before all of this that David just said went into play, we did have town hall meetings to educate the staff on COVID. to try to decrease the anxiety and the fright behind the whole the virus. And then I sent out messages in our on shift to staff that I wanted to offer premium pay to staff that volunteered to work only on the COVID, what we're calling our special care units or the COVID units, just for this phone call, because they would be only working on those units. And they wouldn't be able to, of course, pick up any extra time on our other units because we wanted to avoid any type of cross-contamination, because we do isolate our admissions when they come in from the community, whether it be the hospital or long-term care, assisted living, or the home environment for 14 days. So we really had to dig deep and get staff that wanted to commit and volunteer to do that. And it took a lot of education and just going to the unit and explaining to the staff what this would mean to me, as well as the patients and residents that would be coming into our community for them to care for them. So it was just a lot of education and just the leadership team coming to them and explaining how much it meant to have them on that unit and how important it is and was to get the unit together. And we had to get the special care unit together, we had to completely move about 10 patients off of a hallway and relocate them onto our long-term care units, which entailed, of course, calling their families. They understood. It was a great response, and David was very understanding in that, and he did help make phone calls. It was a complete organizational endeavor. Everybody was helping out because, of course, you do have to care plan and document everything from our social services aspect of it. So we did move everybody to empty one hall. And then to meet the needs of the facility, we do have a clean room on one hallway for our nurses and all of the nourishments, and there is a restroom in there as well. But we took a room out of commission to allow the nursing staff the ability to document in there, and they don't come off the hallway at all. So that is what I call the clean room for the nursing staff, and that's where they stay the whole shift. And then we also emptied another hallway to meet the needs of the hospitals and any other facilities that may need to utilize our services. And we have that hallway prepared as well to, in turn, admit and isolate for our 14-day policy. And we will begin to fill that, I believe, today or tomorrow.
Thanks, Rebecca. I don't know if you can answer this question or Sarah could answer this question. One member heard from their local Department of Health that it's not a good idea now that they've got positive cases to create a COVID-only unit because they're risking more transmission with transferring folks to that unit. So I wonder, Sarah, your thoughts, and Rebecca, yours as well.
We don't transfer internally. We don't transfer from one unit to that hallway. These are admissions only from the hospital or the outside community.
This is Sarah. I agree. It gets really tricky to start moving people once you have positive cases in your facility. And so if that were to happen, you would have to think through that really carefully, because we have been concerned about that just adding to transmission. And so it's better to think, like they're saying, it's better to think through having a designated unit before you have positive patients.
Thank you. A follow-up question for Matt. Which regions of the state showed the increase in self-reporting positive cases?
Yeah, those the main regions, and to preface that, we go by coalition regions, which there are 6 of them within the Commonwealth. Again, obviously, our most impacted regions still remaining the central, which is the greater Richmond area, Eastern Shore, and Northern. But we have started to see increase in cases within the near southwest region, which would be the greater Roanoke area into the New River Valley.
Question came into the chat box. If for anybody who can add to the chat box, if you've put in any type of hero pay or hazard pay, kind of how did you formulate that plan? I'm grateful to hear from David how Beth Shalom worked on that, but we've been hearing that from lots of members trying to understand that. So this is a follow-up, I guess, Sarah. How am I to set up a cohort area for positive cases if we aren't supposed to move residents after they test positive? So I think they wanted some clarification on that.
Sure. I mean, I definitely understand the question. I think every facility is a little bit different, so we're trying to have these conversations at the local level with facilities. If your facility is has any empty space, or can sort of free up a wing or even like a side of the hallway or end of a hallway before you have cases, that's what we're saying, to just sort of have like a designated area in your facility before you have positive cases. And then the decision to move folks once you have positive cases would just have to be a discussion. There really isn't one size fits all. I think we talked last week that CDC doesn't in general recommend moving roommates once one roommate is positive, for example, because that other roommate would already be considered to be exposed. And so that's the problem, is we're seeing pre-symptomatic and asymptomatic people with coronavirus. And so once you have one positive case, you probably actually have more positive cases. And so it gets really tricky to start moving people around. So I think if you have further questions specifically for your facility, I encourage you to reach out to your local health department, or we would be happy to set up a call.
Thanks. Follow-up question for Rebecca and David. Did you play out the scenario that, what if staff didn't want to work in that unit, what you would do?
Yes, we did. And at first, only nursing assistants responded to my plea. And so it was, I told David I would be willing to, because I am a registered nurse, I would be willing to work on that unit. We would have our, frontline, our management team working on the unit, and we would all just, be pitching in. We have plenty of registered nurses and LPNs, the MDS coordinator. We have plenty of staff that would be pitching into work, but we have an amazing team here that once I went down to the unit and explained how the system was, it was like a light bulb went off. It just took the explanation. And then when I mentioned the extra premium pay, they said that's even better. But the CNAs were absolutely amazing, and they were down in my office before they even knew what the pay was, giving me a list they gave me a demand list of what they needed to make it work well and function better for them. And that's really what the staff want, is how to make it work smoothly, even more so than the pay, is to how to get it to work smoothly.
That's a testament to the culture at Beth Shalom, no doubt that was the response that you got. What was on their demand list that either surprised you or that surprised you or wasn't on your list that you had thought of?
It was and it was all for the residents. They wanted to make sure they had their own coffee carafe and their tea pots, and just to make sure they had enough linen down there, snacks, so they wouldn't have to ask the other staff, because we're just making simple terms clean and dirty staff, in layman terms for them. And so that they wouldn't bother the other staff that was doing their assignments down the other hallway, just to make it easier on everybody, so they wouldn't have to keep, hey, can you go get me this or that? Just to have their own supplies, an extra linen cart down on the unit, an extra ice chest, just everything extra. And that's what we did.
One of the things that Rebecca's probably not giving herself enough credit, in one of those rooms, we took a room out of that hallway and we used that as our charting room. And so in that room, there's a refrigerator with milk and juices and sodas and stuff like that, as well as cold snacks, sandwiches, HS snacks, things of that nature for staff, as well as for residents. But again, we just wanted to make sure that people weren't walking back and forth off the unit to fill ice, to resupply everything up. It was a win-win. They really did a terrific job with it.
And is there anything you want to comment on with regards to PPE or testing in your area?
Need more of all of it. That's really it. I mean, we need more of all of it. PPE is still in short supply. I'm sure I'm like every other provider on the phone. You're begging, borrowing, pleading, and buying from anywhere that you can.
And the price gouging.
And of course, the price gouging, it goes without saying. And certainly there needs to be more access to COVID tests.
And David, question came in, did you increase all staff on your campus or just the healthcare staff for the $1, $1.50 per hour?
That was all staff, regardless of whether or not they were working the special care unit or not. If you're working the special care unit and you also got that $1, $1.50, you essentially got $4 or $4.50, or $5 and $5.50.
Dana, a question for you, our resident legal counsel. How do people report price gouging?
My answer to that would be to contact the Attorney General's office. And my husband, formerly with the Attorney General's office, is shaking his head to me, yes.
That co-officing is really working well over at the Parsons household.
Yes, we finally became Parsons and Associates, and the kids are the associates.
Sarah, are you still on the call? I think I saw that you left. And Matt, I don't know if you're still there. The question came in, any reason why the Lord Fairfax Health District is not reporting hospitalizations? I don't know if you knew the answer to that.
I can't speak upon why the health district is not. Our data that comes out of VHOS is VHHA's hospital member reporting data. That does not include any data coming from the health districts.
An 8-hour day.
Thank you. So regarding bonus pay, there's a community in New Jersey that's giving folks bonuses per pay period if they don't call out. And David, have you considered that, or you're just going straight with that hourly increase?
We were just seeing that came in. We've had a lot of success. Now, is this for people in their whole community, or that are just working a special care unit?
I don't know.
It's the whole community.
Huh. It's a great idea. I mean, it gives us thought. We have not considered that. Again, we wanted to get some more money to folks who may have been a little bit more challenged during this.
And I see the next question, wouldn't that encourage people who are sick to work? If you're screening everybody, your screening should pick up the people who are sick, I would hope.
Yeah, I do know a member, a multi-site member in Maryland, Pennsylvania, and Tennessee did that one-time spot bonus in everyone's checks at the beginning of this, and now they're contemplating how to do, whether or not to do the hourly or not. So it's an ongoing conversation, it sounds like.
Yeah.
Thank you, David and Rebecca. Any last thoughts before I hand it over to Dana?
I just want to thank everybody that's in the long-term care community. And I've been calling my local Virginia Beach, my Virginia Department of Health, and her name is Diane. And I just have to give her a shout out because she's absolutely amazing. She's my bestie now. And I just have to thank everybody for what y'all are doing. And LeadingAge, thank you all so much.
Thank you. David, you've lost bestie status.
I know.
He's never been my bestie.
I know. You'll have to increase my pay.
Thank you all for everything. Dana, I'm going to turn it back to you.
Yeah, so Eric Bodine with the Certificate of Public Need, we've been trying to get him on. Are you able to speak to us now? Okay. Well, I want to let you know that that information that he was going to share with you, we will include it in our daily update. I will also include information about reporting price gouging, who at the Attorney General's office and how you would go about doing that. Before we hang up, I just want to give another opportunity for anyone to put any questions in the chat box that they'd like to bring up at this time, since we have this time together before we end. Okay, well, our next call will be on Wednesday, April 22nd at 11 a.m. Just know that we're here for you. Please let us know how we can help you, and you all are continue to be in our thoughts and prayers.